already in the system in terms of what we're building on to do. And so here you see two approaches that we're using. On the left-hand side is TASH that I was talking about, which is our intervention. That is our hypertension intervention that we're giving to the people with HIV and hypertension in terms of the clinical treatment. And TASH goes through 4 different steps. So it's identifying those patients with hypertension, counseling those patients on lifestyle habits or modifications, treating them with medications needed based on the Nigerian Simplified Protocol for Hypertension Treatment that's already in the system, and then referring those with complicated cases to further care to the physician. So that's what the nurses are doing in the primary healthcare centers. But then on the right-hand side, you see the practice facilitation. Practice facilitation is essentially us training these senior nurses to support the nurses so that they can actually give the care to the patients, right? So it's external support, and what it does is that we have a site champion in terms of a coordinator at the primary healthcare centers. We have to build consensus in terms of actually improving. So these practice facilitators, you can call them practice coaches. When they go and they work with the nurses, they're always trying to figure out where can we improve the quality of care for people with hypertension. And then there's also the peer-to-peer collaboration where we have the practice facilitators for our MAPIT setting. We have 6 of them who are part of the network, and they oversee roughly 30 primary healthcare centers in Aifah. I'll show you a map in a little bit of where we're working at. So our main study outcomes, and again, this is a study. There's a time period where we have roughly like 2 or 3 more years to do this work. But by the end of MAPIT, what we're hoping to see is that within the primary healthcare centers, the nurses and the PHCs will be able to adopt the TASH intervention. That's the hypertension treatment or program that we're offering. And then our secondary outcomes is that we're hoping that because of TASH, people living with HIV who have hypertension will have better BP control, right? And then hopefully we can also see that within the PHCs, they've been able to implement TASH well for the period that we are working with them, as well as sustaining TASH over the course of time. All right, so I mentioned before that the nurses are providing hypertension treatment. This treatment is based on the National Hypertension Control Initiative, which is a policy or program here in Nigeria that's available, so we didn't create anything new. We're just asking the nurses to follow the steps in terms of the kind of medication that they provide. I'm going to pause real quick. Dr. DK Oji, I mentioned before, the principal investigator, he's here in the house. Dr. Oji, do you want to wave your hand to the crowd? That's Dr. Oji. He is from the University of Abuja, as I mentioned before. He is the main man, the overseer, the one in charge. So doing a great job in terms of leading the effort. All right, so let me get back to this slide. So that's the hypertension program. We have our inclusion and exclusion criteria for our patients. Of course, they have to be over the ages of 18, what have you. So that's not too important for you, but just general in terms of the study. So now this is where we can pay a little bit of attention at. So this is where we're based at. We're at 18 local government authorities here. We have communities, in terms of collaborators and partners, we're working with each of the LGAs, as well as support groups, and there are 30 primary healthcare centers that we're working with, okay, for the MAPIT study. This is a listing of all the places. I'm sure you all will probably be more familiar with these PhDs than I am, but again, covering the breadth, and if you want a closer look, this green area on this big map also shows where we're based. We'll talk more about it later. But this is a list of all the primary healthcare centers that we're working at. All right, going down to the 30. All right, that's the list. And then just to show that part of even why we're here, we're also doing a hypertension training academy. We've been doing a lot of training and capacity building for nurses, physicians as well over the years that we've been working, starting in 2021. So those are some pictures of me seeing the nurses as well as the practice facilitators that we train. One thing that I want to emphasize with the work with MAPIT is that in order to work, MAPIT is really relying on already what's in the system. Who are the people that are already doing the work that we can work with, right? And so that's going to be important for how we're also thinking about engaging more of community-based organizations like you all. All right, so now we'll talk a little bit more about our stakeholder engagement. I'm going to pass it on to Mr. Daniel Henry, who's the program manager, to talk a little bit more about that, and then I'll see you all in a little bit.
Good morning, everyone. So my name is Daniel. I'm going to be following our friend from where she stopped. Quickly, why are we here? And I want to let us have a better perspective of the goals and why we are here. Number one, we simply want to understand us more. That is one of the major reasons we are here, to understand our stakeholders. You're sitting here because your work is related to HIV care management at the community level and or NCD care management also at the community level. You may not necessarily be doing treatment, you may not necessarily be doing much for now, but for the fact that you engage or you service clients living with HIV at the community level, either through preventive services or you provide treatment services, that is why we are here. The next reason why we are here is to explore practical ways, context specific. What are we currently doing? Where can we fit in? Where can we work together? That is why we both are talking. So few months ago, we engaged with people that we are already working with, that is the healthcare workers across the facilities. We engaged with policy makers. We also engaged with program managers across different providers to learn from them so far what have we been doing, what can we do differently, what can we strengthen. That is as per what is already happening in the field. And at the end of this engagement, part of what we got from these people was that stakeholders was strong recommendations on strengthening community approaches to care. That is another reason why we are here. Remember that we are trying to build a foundation as to what we are here and why come. And in all of that, as you can see, community clinical linkage is key. In fact, it's topping the agenda. In case you are not sure what we mean, because most of us here, we have engaged with us more than once, and in all our conversations, you probably kept hearing community clinical linkage. We are just saying, we want to link people that we are already providing care to, that are in the community, to the clinic. That is the short and long story of all we are saying. We know we are already seeing these clients at the community level. We are saying, how can we help these people get linked to a health center where they can access other services, specifically non-communicable disease. And that is the educational program. When we mean educational program, most of us are very familiar with IEC materials and is awareness and sensitization. This is what we want to strengthen. From the interactions we've had so far with almost all the groups sitting here, we all have a strong educational programs ongoing. We want to see how can we build and better on this. Next is policy level change through policy brief. What we are doing or what we intend doing with us, we want it to transcend beyond what we are used to, working in community and making referrals. Can we translate to a policy brief? Can we translate to an actionable? Can we translate to something that is sustainable, something that will outlive me and you? In the event where you are no longer there, in the event where I'm no longer there, can the generation of people that are taking over from us, can they build on what we are already, what we have done, or what we plan to do? Now, what are the challenges that we saw so far in the course of our work? Dr. Aifah talked about activities on MAPIT so far, and in all those activities, did we experience or identify any challenge? And as you can see on the screen, the key challenge we experienced was that most of the patients that visit these clinics are not working clients. Most of the patients that visit the clinic for HIV service provision come from the community. So we are now asking, if they come from the community, how can we better reach out to them since they are from the community, so that everyone will have access to NCD care? And the solution that we tried working around was, number one, we tried to look at NEPWAN. What is NEPWAN doing at the state level? NEPWAN have a couple of support groups spread across the state. We try to engage a lot of them, to work with them, to meet with them. Most times they meet once monthly, mostly on Saturdays. In some cases, we try to join them in their meetings. In some cases, we try to provide them with some tools they may need to work. I think at some point, we also try to provide some trainings for their leaders so that they can cascade those knowledge to their different support groups. We also try to leverage what the HIV partners we are already doing. As we all know, FHI, which grew to ANI, from ANI to AQs, they are doing so much in terms of HIV service provision at the community level. So we try to work with these folks. How? We try to provide them with BP monitors so that as they go to refuel their clients, as they go to see their clients at the community level, they can also check their blood pressure. The ones that require attention, they refer back to the clinic. At some point too, we join them. I think currently most of the PSCs now are doing some level of sensitization and awareness at the community level. This is in close partnership with both the AQs team and the health facility team, and in some cases the MAPIT team also join them. All of this is to see how we can harness what is in the community. Now beyond that, there is linkage to MAPIT, which is why me and you are congregated here. And linkage to MAPIT, what are we saying? We are now saying that we have explored solution one, which is support group. Support group is a group of HIV people that gather to encourage themselves in terms of adherence, retention, and all that. We have also explored working with the community teams of different HIV IPs at the clinic level. Now we are at solution 3, which is you. That is why we are here. How do I mean you? You, because we are looking to establish a relationship whereby all your clients or all the clients you service or support at the community level, we want to see, is it possible for us to expose them to NCD care at the facilities? Alright, the building blocks for HIV NCD integration at the community level. Okay, so my next slide is talking about why link to MAPIT. Why are we doing link to MAPIT? I think I have a lot spoken on this. We now would like to work towards enhancing the goals by building a link between people living with HIV and the clinics. I've talked a lot about this. If you don't get anything from my presentation, please get the fact that our goal is to see to a large extent. We know that, due to differentiated service delivery model that is currently ongoing, is difficult. But with the right awareness messages campaign, that's why we talked about educational programs, we think that it is doable. And we're also thinking that with a well-established HIV care treatment and infrastructure, community-based and led approach can improve this. What we do matters. What we tell these folks matters. We all here cover different communities. In a short while, this map here is to help us identify our strengths, identify what we do, identify areas of collaboration so that we don't duplicate efforts. So at the end of the day, our goal is to link these folks back to the clinic. Now, these are short-term and long-term goals. To be clear, the short-term goal, which we all will start seeing shortly after we leave here, we want to see, is it possible to identify potential opportunities for creating a community clinical linkage for hypertension management while building the capacity of community-based organization to sustain and link community clinic linkage. We want to identify what we have as strengths. We from the survey feedback we got, we were able to harness a lot of it, and that is basically going to form our discussion today. Now, the specific aim of this link to MAPIT, aim one is to conduct a community access mapping of the resources and capacity of the estimated CBOs of people living with HIV. We have passed this stage, which many of us participated. And the next one is use a human-centered design approach to work with the local advisory committee. This committee comprises of many health stakeholders in the state who support what we do. We have members from the Ministry of Health, from SACA, Primary Healthcare Agency, Local Government Service Commission, University of Uyo Teaching Hospital, across board. And lastly, why CAM? We want to identify our resources. I've talked about that. Strengthen community-based and led approach to improve HIV and HCV outcomes, and identify the key building blocks for establishing a hypertension community clinic linkage among people living with HIV. Lastly, alright, you may not see a lot from this map, but this basically summarizes everything I have just said. Discussions, questions? That's why I quickly took that back. Will anybody want to provide any or ask any questions before we go for our tea break?
I'm also curious, can we start talking about when you hear a community clinical linkage, what stands out for you maybe in the work that you're doing now?
At least me thinking about it for today. So everything that we're doing today is about community clinical linkage. How can we set it up well for hypertension? So based on what we talked about, when Daniel was laid out, talking about us trying to understand the resources that you have, is there anything that's standing out that you want to highlight now or bring to the table? We're going to talk more about it throughout the day, but since we have time before we go to our tea break, I think we can open it up. Are there any thoughts on the community clinical linkage that we should be maybe thinking through now? Very quietly. You all have to have tea before you can start. We have to go to tea first. No, any thoughts?
We are following it. So before we get to the tea
So
break,
we use time for tea, let's have tea.
let's have it.
Okay. Tea break then.